screen, the keynote,
Yes.
without the presenter notes?
Correct.
It's just
All right, good. I've got the presenter notes up on my iPad anyways, so this is, looks like it's actually working.
Yeah, it's actually been pretty like good on this.
Great.
Do we have to admit everybody? I thought this was, you just click on the link.
No, I think we made it so that you still have to go to the waiting room so no one can like Zoom bomb us.
no Zoom bombing. It's Zoom bombing.
Yeah, okay.
It's one little.
Should I go ahead and get started, or should I?
Let's give like 2 minutes, and yes.
Okay. And is there like a hard time when you want me to be finished by?
Like 9:05, 9:10.
Okay, sounds good.
Huh. Thanks for the info, Molly. Didn't know that. All right, looks like we're probably at a steady state of 31 now. So if you want to start sharing and start Henry, that'd be great.
All right, I'm ready. It didn't feel right without the bow tie. Am I still, no, can you still, anyway, let me just.
Right now we're on the speaker notes page.
Okay. I bet maybe I screwed it up. Is that better?
Yes.
All right. So my talk was meant to be about pain medication use and abuse, and I added in some information about our Alto, and as well as kind of general alternatives to opioids. I mean, I think everybody knows you can just keep giving enough opioids, and eventually you'll have the patient sedated and with minimal to no pain, but there can be a better way with less side effects, less sedation, pruritus, addiction, etc. So I'm going to try and walk through some of those things. So why not opioids? I kind of went through some of the side effects already, but there's certainly side effects from the use of opioids. Of course, addiction is one. We've kind of disproven the thought that, the use of opioids will obscure our exam, but still there's plenty of reasons not to use the opioids for pain, at least as our first line. So, what is their efficacy? It gets certainly reduced as our patients begin to develop tolerance, or patients on chronic opioids have reduced efficacy of opioids, both because of tolerance, but also from something called opioid-induced hyperalgesia. And so for everyone who's not aware of what that is, it can be demonstrated both in the lab as well as with specific patients, human patients, with either a cold pressor test where they put their hand in a cold bucket of water, and if they have opioids on board, it actually makes them feel more pain from that stimuli, or they have increased sensitivity to pain after something like a surgery if they're getting opioids instead of non-opioids. And so what opioid-induced hyperalgesia is, you can demonstrate it in mice where if you start a mouse on morphine and you do this heat kind of pain test on their tail and see how often they flick their tail, after one dose of morphine, they have less pain related to heat. But if they keep them on that morphine for a couple of days and they repeat it again, they find that the mouse has more pain. They're flicking their tail more, despite the fact that they still have opioids on board. They actually have a greater expression of pain, a greater sensitivity to pain than than a mouse that's opioid naive. So you may wonder, why are patients who are either injecting opioids or on chronic pain medicine or whatever it might be scream when someone tries to touch them with an IV. And part of it may be a little bit of histrionics, but they actually do have a greater sensitivity to pain in these patients. And so it's reasonable to have some empathy towards that their experience may not be the exact same as yours because of the medications they've been exposed to in the past. So to start with alternative to opioids, we have a couple of ways to access it within our order sets. We've got our ED Alto order set up on top there, and below we've got our quick lists that I'm just going to very briefly run through what's on it, because then we're going to talk about the components just so you have something to remember when you guys are looking through it. So here's our musculoskeletal one. It's got all the common acetaminophen, NSAIDs, lidocaine patches, muscle relaxants, and sedatives, including diazepam, neuropathic pain meds, other anti-inflammatories, dexamethasone and prednisone. And then, of course, we add on ketamine there. Those are all kind of quickly selectable. You can just click, click, click to try a number of things before you move on to opioids. Same thing with kidney stones, similar stuff, has some fluid in there, has the ability to use pain dose lidocaine, intravenous lidocaine for pain. Its probably best indication is for kidney stones. It may be useful elsewhere, but we'll talk a little bit more. It's not really clear exactly where that fits in. Abdominal pain, again, there's a number of things we can try before we get to opioids. For acute pain, concern for cholecystitis or appendicitis, certainly Toradol is a totally reasonable first-line analgesic. For things more like abdominal migraines or chronic pain, sometimes some antiemetics or Haldol or Bentyl can be more of a reasonable option, but can also move on to those ketamines and lidocaines. Fracture dislocations do not all require opioids. We'll go over a little bit of data, but specifically in kids that actually ibuprofen is superior to codeine for treatment of fracture pain. Of course, you can do nerve blocks with some lidocaine or hematoma blocks, those sorts of things. And ketamine, again, is always an analgesic. Subdissociative dose ketamine is always an analgesic option. I think we usually practice this for pharyngitis is attempting a lot of alternatives to opioids. I don't see a lot of people using opioids for pharyngitis. Sickle cell, we have in as supplements to opioids, just given that I think most recognize that opioids are the standard of care for a sickle cell crisis. We've got an order in for some hypotonic saline in there to help decrease the sickling as well. But we can add things onto it. So it's been shown repeatedly that by adding on non-opioid analgesics to opioids, we're able to decrease a patient's opioid requirement and get superior pain control. So while this is true of our sickle cell patients, it's true of our other patients as well. So perhaps starting or adding an alternative to an opioid can help our patients. And then we've got an entirely separate headache protocol, but it is also inserted into our alternatives protocol as well. So let's run through a couple of options for things that are done both in the emergency department and on discharge for pain. So I'll pose a rhetorical question. Would you give your patient a medication that 30% of them are going to be underdosed or overdosed on by giving them the medication? Would you just kind of roll the dice and say, I don't know what dose you're going to get? Well, then do not give your patients codeine, either on discharge or in the department. There is really no good indication for codeine. It is a prodrug for morphine. It gets metabolized into morphine by CYP2D6. So some of our patients will get a big rush of morphine, and some of our patients will get almost none due to variabilities in that CYP2D6. And because of this risk of getting this big rush of morphine, there have been a couple of deaths in children, primarily post-tonsillectomy and anoinectomy, these kids who have already issues with an airway potentially, but we have better, more predictable analgesics, ones that do not rely on CYP2D6, so I would not give your patients codeine. Another rhetorical question would give your patient a handful of morphine and a handful of venlafaxine and SNRI and tell them to take whatever dose they feel like for their pain. Is that your general approach to pain treatment? Have them open their mouth and just throw a handful of pills and see what lands? If that's not your approach, then don't give tramadol. It is another drug that is metabolized by CYP2D6. It starts out as primarily an SNRI, a serotonin and norepinephrine reuptake inhibitor. And then it gets metabolized by CYP2D6, again, at this varying rate, to a potent opioid. And so one group of patients may get a large SNRI effect, and another group of patients may get a large opioid effect. And again, you don't know what they're going to get. In addition, those that get the big SNRI effect, if they're already on an SSRI or other serotonergic drug, can certainly suffer the serotonergic side effects of it. But you might say, well, tramadol's not addictive. So it is not. It is not non-addictive. It's been shown to be a drug of abuse, primarily in other areas where there's just ready access to it a little bit more, but it's a huge problem in some countries, such as Egypt and some areas in Europe, as a recreational drug. The thought that it's non-addictive is based on this one study that, again, on the left there, you see morphine being reinforcing, and on the right, you see tramadol as being less reinforcing until you get to high doses. It turns out this study was done with IV tramadol. And if you need first pass metabolism for a drug to be converted into an opioid, of course IV is going to be less reinforcing because you get less of an opioid effect. So this was a poorly done study that does not indicate clinical practice. When you actually study oral drug versus oral drug, it's found to be just as reinforcing and addictive potentially as other opioids. So tramadol is an opioid. It is addictive. It is serotonergic. You don't know how serotonergic or how much of an opioid, so don't use tramadol. It's also been shown to be risky in kids, particularly, again, undergoing tonsillectomy has been associated with deaths related to that too. So don't give it to kids either. So when we start talking about opioids, the question of, well, which one should we use? If we're moving to opioids, and certainly there's absolutely a time and a place for opioids. So there's a lot of hydromorphone use out there. A lot of patients might say it's the only thing that helps for my pain. We might like to give a nice round 1 milligram number to our patients. But it turns out that hydromorphone is no more efficacious, is at least not clinically significantly more efficacious. You may be able to find a study here or there that has appropriate dosing and finds it to be just the tiniest bit perhaps more rapid in onset. The reason it's more rapid in onset is because it's 10 times more lipophilic than morphine. So on the left, we have hydromorphone. On the right, we have morphine. We have all these polar hydroxyl groups on the morphine on the right, and we have some non-polar carbonyl groups. That double bond to that oxygen is more non-polar. It rushes into the brain. It's reinforcing. It's been shown to be preferred, similar to heroin for people who use such things. And so there's not a good reason to go to hydromorphone ahead of morphine. People may say there's less side effects. It turns out that those are dose related, right? The pruritus, the nausea, vomiting ends up being basically equivalent to morphine if it's given in equal doses. So 1 milligram of hydromorphone is equivalent to somewhere between 7 and 10 milligrams of morphine. And so unless you're starting with your morphine dose at 7 to 10 milligrams, I would not start with a dose of hydromorphone of 1 milligram. You want to kind of decide and compare apples to apples. What should you be giving your patients? And so again, just kind of comparing here, the hydromorphone to the heroin. Heroin is diacetylmorphine. It's got those 2 acetyl groups on the right there. Again, these non-polar groups, lots of double bonds to oxygens that allow it to cross into the brain very quickly and be reinforcing. So I would not recommend widespread use of hydromorphone. It is not better for pain control, and it is more reinforcing. So I would choose morphine in most circumstances if I'm going to use full agonist opioids. So what should we do? I've had lots of things that I'm naysaying against. Again, certainly in appropriate circumstances with acute pain, opioids are appropriate. I use plenty of opioids on my shift. So don't get me wrong that I'm just kind of railing against their use. But what else should we do? What should we try first, or what should we try adding to our opioids for pain control? So there certainly are a number of non-pharmacologic strategies to manage injuries. I think, a lot of these in our department are kind of the nurses will start for us, but certainly immobilizing, using ice or heating packs. We've done some trials on TENS units that are certainly an option. Other things that we tend to do more with our kids, if we could only get an adult life department to help us with our adults and their pain, to help them with adequate preparation, imagery, distraction, relaxation, creating a comfortable environment. These are strategies that can help any of our patients, not just our kids. We focus on doing these things with the children, but certainly adults can benefit from all of these strategies to help with pain. But what about for medications? What medications might be helpful? So of course, ultrasound-related nerve blocks can be helpful for extremity pain in particular. Nitrous oxide is an option. We don't have it in our department, but if you see it out there, it can be useful for acute pain. Patient comes in with a fracture, you're working to get an IV on them to give them that dose of Toradol. You could always give that dose IM, but if you're just working on it, you can get them started on some nitrous oxide and keep going from there. And then certainly you can start to look at, what is the specific treatment for the syndrome that you have, right? If someone has, some clearly neuropathic pain, maybe getting them started on some gabapentin. Trigeminal neuralgia, right? The treatment is carbamazepine. Cluster headache, we try oxygen instead of opioids. If they have muscle spasm, that's where we can go to our central muscle relaxants, right? I differentiate central muscle relaxants from muscle relaxants. I would not give your patients rocuronium or succinylcholine. So really all of our muscle relaxants, quote unquote, are really just sedatives, and they can relax the muscles that way. I am a fan of tizanidine because it's an alpha-2 agonist, which by its sympatholytic activity, these alpha-2 agonists have been shown to have benefit for pain in their own right. So it may have this central muscle relaxant effect, and it has this alpha-2 agonism that is helpful with pain. So I am a fan of the tizanidine and adding onto that. And what about our patients who come in with mild to moderate pain, may not need an IV? Well, in that case, I say ibuprofen and acetaminophen rule. They're the best option for our patients. They've been studied for single dose oral opioid and non-opioid analgesics in acute extremity pain, right? So I think it's a pretty common practice. A patient comes in and they have a sprain or they have potentially a fracture. We say, okay, well, give them a Norco or two to start, and then we'll send them out on whatever we feel is appropriate. But in the end, it was studied. Patients were randomized, 416 patients, to either receive acetaminophen and ibuprofen versus a Percocet or a Norco or a Tylenol 3. And their average pain in this was 8.7, despite the fact that large number of them were sprains and strains. But in the end, when they randomized these patients to, again, 400 of ibuprofen, which has been studied subsequently and found to be the appropriate analgesic dose ibuprofen, 400 milligrams is just as effective as 800 for analgesia. So if you add 400 of ibuprofen to a gram of acetaminophen, it was found to be equivalent to, again, either a Percocet, a Norco, or a T3. They had equivalent pain outcomes in this study. And so again, for this mild to moderate pain, start with a Tylenol and ibuprofen. And certainly you can always escalate from there and give them an oxycodone, again, if they require it. Similarly, they took 244 kids in a different study, this Drendel study. 244 kids, they all had arm fracture pain, so they all had a fracture, and they were prescribed ibuprofen versus codeine. And what they found was that there was more treatment failure in patients who were prescribed the codeine, a trend towards more. So it was non-significant, but at least, there was not a trend towards worse pain control with the ibuprofen. They were equivalent for pain control at very worst. But what they also found was there was significantly less adverse effects. So significantly less nausea, vomiting, and kind of any side effects. And then this trend towards less drowsiness, dizziness, and other side effects with the ibuprofen. They also, when they kind of did a subjective analysis and talked to people about their experience, they found that parents and their children were less satisfied with the Tylenol codeine, saying that it tasted worse, and probably because of those side effects. They were less satisfied, and they found that their functional status was improved with ibuprofen, right? So the kids were drowsy, dizzy, nauseous, and vomiting with the codeine, and they were able to get up and move around with their ibuprofen. And so for kids, again, even with some fracture pain, they should at least go out on ibuprofen. They don't need a prescription for codeine, and much less, some other analgesic, right? So we know that codeine is not an ideal analgesic. But I would not say, okay, well then let's just use hydrocodone. I would say that ibuprofen provided adequate pain control and good functional status for these patients. You might say, well, what about the risk of fracture non-union that we hear from ortho all the time? I would go back to this and some other studies that have kids randomized and say that there were no episodes of fracture non-union in these studies. Again, these were arm fractures. They were not, large traumatic fractures. They were not spine surgeries. So I'm not saying that it can necessarily be generalized everywhere, but there were no episodes of non-union. And when we start talking about what is the data behind fracture non-union and the use of NSAIDs, what we find associates them are these animal studies. A bunch of orthopedists break a bunch of rabbit bones. They give them high NSAID doses, kind of what we would think would be supratherapeutic NSAID doses, and find a higher incidence of fracture non-union in these animals. And then we also have a lot of non-randomized, or I don't know about a lot, but we have a number of non-randomized and retrospective studies that show this association between higher NSAID use and more non-union. The alternative explanation to the NSAID use is that those people who are having more pain probably have a more severe injury and are more likely to have non-union of their fractures. And again, so if we look at these randomized studies, we see no incidences of fracture non-union for people treated with NSAIDs. And so, again, for our minor fractures, for sure, not these severe fractures that have a ton of pain and that we're getting ortho involved with, I think NSAIDs are an appropriate treatment for fracture-related pain. Toradol or ketorolac is as good as morphine. Probably is not any better than ibuprofen. It's been studied in a variety of studies, and this 10 milligram IV dose is what's found to be the appropriate, again, analgesic dose for ketorolac. It tends, at least in our department, to come in 15, so I usually will prescribe 15s, but that's certainly still better than the 30s and 60s that we're giving out. So again, to limit side effects, going with a 10 milligram dose should have the analgesic efficacy of morphine. So again, if you were going to start with just a dose of morphine, again, in a patient where you're concerned with appendicitis, why not start with just a dose of ketorolac and see how they do? If you were going to start with multimodal analgesia, they're having tons of pain, they need morphine, they need Toradol, they need Tylenol, they need everything, then fine, then you can stick with the opioids. But if you're going to go with a single agent, there's not a good reason, and if there's not a good reason to not start with an NSAID, then I would start with that. There are several studies that show that ketorolac provides the same analgesia as oral ibuprofen, and that oral ibuprofen has a rapid time of onset. So again, outside of keeping a patient NPO, there's not a good reason not to go with ibuprofen actually as an initial pain option. Again, for our patients who might be going to an OR or something, sure, give them some ketorolac to start with their pain. There may be a subset of patients who really prefer an injection, but again, I think that starting with ibuprofen is reasonable. So again, this is that trial I told you about where that showed that the pain dose of ketorolac is 10 milligrams. It's not better at 15. It's certainly not better at 30. So sticking with that 10 milligram dose. And here's a study that I really like that looks at this question of, do patients across the board feel like they get better pain control with an injection versus an oral medication? So in this study, they took 64 patients and they gave them all ibuprofen concealed in a drink. So they gave them a drink and said, here, everybody drink this juice. And everybody got ibuprofen to help them with their pain, and everyone's pain improved over time. And then they gave some patients a sham injection or a sham pill. And they said, okay, this is your medication, a placebo pill or a placebo injection, even though they all got ibuprofen, just to see if those that got the injection might say, okay, now my pain is better through the placebo effect. And they found, again, these lines are completely matched up, as those that got the placebo pill or those who thought they got a medicine through IM had equivalent pain. So again, I know there's some patients out there who really want something through the IV. They might actually just ask for it. So it's not unreasonable to give those patients Toradol, even if they're not NPO. But sticking with the oral meds is not a bad place to start. And again, it's been studied. Morphine is equivalent to Toradol. I know these graphs are not that great to be able to interpret. So again, I think we can see that different patients might have a differing response to one medication or another. These are all kind of individualized patients' pain scores that we're seeing here. But that morphine is equivalent to Toradol in renal colic. But what we also have found is that the combination of the two is actually synergistic. So if you feel like giving a patient, if you've given them morphine to start with and their pain's not better controlled, the answer might not always be more morphine. It might be, okay, what other opioid alternatives do I have to add to help me achieve that better pain control, to help me achieve that kind of synergistic response. So acetaminophen is a good option for our patients, and it is available in a PO formulation. So while I might cite a study or two here or there that talks about IV acetaminophen, there's really minimal data showing that the IV is actually superior to oral acetaminophen. People talk about first pass metabolism and those sorts of things, be able to give a little bit higher dose. It doesn't seem like it's much superior, and so acetaminophen is a helpful analgesic for our patients. Again, if you see, so there's this trial that looked at the treatment of renal colic, right? An easily definable, painful condition seen in the emergency department. That's part of the reason why we see a lot of studies on that, is that we can kind of quantify and say it's severe pain. And what they found is that comparing the diclofenac versus acetaminophen versus morphine, that these patients all had a good 50% or so decrease in their pain score, and then the morphine was equivalent to IV acetaminophen. And again, in these studies, they're all basically using the 0.1 milligrams per kilo morphine dose as a standard dose. And here we see our graph here that's saying that they're having equivalent pain control between these different options. So you might be able to get the most ideal pain control by a combination of them, but if a patient has satisfactory control with some combination of acetaminophen and ketorolac or ibuprofen, then there's not necessarily a need to move on to more. They will have a synergistic effect, but you could certainly start with the non-opioid meds. If you're looking at studies or the conclusions from these studies that try and do a meta-analysis of what is the role of IV acetaminophen, I think in general, we can find that it's helpful. Acetaminophen is helpful, but the main reason to give it IV is because you don't have enteral access, that you can't give them PO meds for whatever reason. So So what they conclude in these in a couple of different meta-analysis, and they have different conclusions. These are from two different analyses, but they say 14 RCTs with various flaws provide limited evidence to support the use of IV acetaminophen as the primary analgesic for acute pain control in patients who present to the ED. To me, again, looking at a number of these studies, it shows, yes, acetaminophen works for pain. No matter what your patients tell you, acetaminophen is a pain medication. And then looking at another analysis, they found that the data for the efficacy, safety, and opioid-sparing effects and cost-benefit analysis of IV acetaminophen for renal colic were weak. And so they say that IV acetaminophen should not be considered an alternative to opioids or NSAIDs for the primary management of renal colic in the ED. Again, the idea is that IV acetaminophen is really expensive. If you can give them oral meds, might as well give that. Otherwise, there's not a harm to sticking with your NSAID. So IV might not be the necessary route. It's probably not worth it, the cost to use it, but acetaminophen is an effective medication, as we see in some variety of other studies, that it can have comparable efficacy to morphine or NSAIDs. What about our urophenones, such as droperidol or haloperidol? So they've been shown in a number of studies to be particularly effective. Can you guys still hear me? My thing says my internet connection is unstable.
It went fuzzy for a little bit, but you're back on now.
All right. So droperidol or haloperidol can be particularly effective for our patients who have had exposure to opioids. So again, whether it's through a modulation of opioid-induced hyperalgesia or through a variety of other mechanisms, it's thought that the right dopaminergic mechanism of these medications may modulate pain signaling. There may be some direct modulation of opioid receptors. Again, droperidol specifically has some increased anticholinergic and alpha-2 effects, which can be helpful for pain in their own right. So droperidol itself is particularly thought to be helpful for pain. Again, for these kind of chronic abdominal pain patients with lots of opioid exposure, that's who we tend to go to this medication for. But haloperidol has been shown to be helpful for a variety of conditions, painful conditions, a lot of abdominal pain, and particularly this gastroparesis. Here's one study that compared patients, right? These gastroparesis patients come to the ER a lot. They're kind of we see them returning time and time again. It's a recurrent condition, or a condition with recurrent exacerbations. And so what they did is they did a retrospective look at patients, and they compared visits where a single patient either received haloperidol, and then they took that visit where the patient received haloperidol, and they compared it to a visit where that same patient did not receive haloperidol. And they found that in the visits where patients received haloperidol for their gastroparesis symptoms, they had less admissions and less morphine use. So again, for our gastroparetics, chronic abdominal pain, patient with other kind of opioid exposures, and that's potentially giving droperidol or haloperidol can be a good kind of first start. And some people will advocate for this approach and say, well, why don't you start with a couple doses of haloperidol or droperidol? If that's not working, the patient will likely be a little bit sedated, and that might help ameliorate effects if you move on to pain dose ketamine. But anyway, first we'll talk about lidocaine. And so how might we use lidocaine? So we can actually use it IV, right? We all know, we have some kind of use of patches and stuff, which is not totally backed up in the literature, but certainly worth a try. And we all have kind of anecdotal experiences, certainly of our patients with musculoskeletal pain, that those patches can help. Certainly nerve blocks can help, right? But what about IV lidocaine? I would say I would consider an EKG and tele while you're doing it, but it's thought to be effective for visceral, neuropathic, or ischemic pain, these kind of decentralized pain syndromes, right? So if you have a fracture with a lot of inflammation and stuff, then maybe IV lidocaine is not necessarily the best treatment for you. But if you have these kind of non-specific diffuse pain causes of pain, then the IV lidocaine can modulate your sodium channels and help you with your pain. So again, there's a variety, there's lots of studies out there. Some show some benefits, some don't. But in some of these studies, we're able to show a real benefit from IV lidocaine, again, specifically for this visceral pain related to renal colic. It's been shown in a couple of studies to be equivalent to morphine. If we look at them, the side effects from it, we do see a degree of side effects with the lidocaine, right? That's group 1. We have more of that perioral numbness, a little bit of dizziness, dysarthria, but we still have 87.5 without side effect, just like when we give opioids. Again, they may have hypotension, vertigo, nausea, vomiting, and again, around 87% without side effects. So in some studies, lidocaine can be very effective. If we start to look at the literature as a whole, from a paper in Annals that did a review on the topic, their statement is a little less bullish on it, so saying that there's limited current evidence to define the role of intravenous lidocaine as an analgesic for patients with acute renal colic or critical limb ischemia in the ED, and that its efficacy for other indications has not been tested. The safety of lidocaine for ED pain management has not been adequately examined. What I would say is that there was basically one severe side effect that's been reported in the literature, and it was from an accidental, basically, overdose in the hospital. They gave greater than the toxic dose to the patient, and the patient had some toxicity. So if you stay well below the kind of 4 milligram per kilogram toxic dose, you'll be perfectly safe to give the 1.5 milligrams per kilogram. Again, for an abundance of caution, doing an EKG, making sure that there's not an AV block or something going on, and keeping them on tele during the infusion certainly makes sense, because we know its mechanism of action. But there have not been side effects reported in the literature. I would say it's an option for a variety of these pain syndromes. It's been shown to be useful occasionally in headaches and things. Again, so it's something that's out there that does not have. I think the jury is still out on it at this point. We're still working on determining what its best use is. So again, talking about subdissociative dose ketamine, they may or may not be pre-treated with a dose or 2 of haloperidol. Ketamine can be useful. It's an NMDA receptor antagonist. Can be useful, again, for traumatic pain, for headache pain, for chronic abdominal pain. It modulates our pain pathways themselves, and so can be useful in a variety of conditions. It is amongst the many things that have been shown to be good as morphine, right? I showed you a study, ketorolac is good as morphine in certain circumstances. Acetaminophen is, the lidocaine can be. Ketamine in doses of 0.1 to 0.3 milligrams per kilogram IV push, or it's been studied that we actually get less side effects if we give that dose via IV piggyback. So we give it a little bit slower, people get a little less of the dissociative side effects of it. So if we give it in that dose or via IV piggyback, it can be comparable to morphine. So again, in a couple of trials, if we take patients and we give them either ketamine or morphine for their acute pain in the ER, we see that they have similar analgesic efficacy. Having said that, there are more minor side effects that seem to be reported with ketamine, dizziness, disorientation. So it's worth kind of counseling your patients on it. Again, if they end up being pre-treated with some other medication that might be helpful, but is not necessary. But I think counseling them, saying you might feel a little dizzy, a little out of it, that's okay, and treating them with that would be a reasonable approach. Again, particularly in our patients with opioid dependence. Not everyone has an opioid use disorder, but if they're dependent on opioids and are suffering from opioid tolerance or opioid-induced hyperalgesia, we've kind of lost the efficacy, and I have this discussion with my patients, is that we've kind of lost the efficacy of our opioid receptor to help us deal with your pain. Particularly with my chronic pain patients, that's a conversation I have with them. And I say, so we have to start focusing on other receptors. We have to work on anti-inflammatories. We have to focus on serotonin, norepinephrine, NMDA, et cetera, to help them with their pain. And so particularly for those patients, ketamine would be a a good option. Patients that you might be worried about getting hypotensive from a dose of morphine, ketamine can be a little more blood pressure neutral. So migraines, there are 99 things to try, and Dilaudid is not one of them. I have a whole toolbox of things. I feel like I never really run out of options on my migraines. I just kind of decide at some point that their case is complicated. They failed a lot of them in the past. Let's just get neuro involved because they failed lots of things. But we can keep on going down the list here. So the American Headache Society is very clear on the role of opioids for migraine headaches. And it is that morphine and hydromorphone are best avoided as first-line therapy. And so I use this statement for my patients who are coming in with headache. If they're asking for Dilaudid, I say the American Headache Society is very clear that we should not be using morphine and hydromorphone, and let's try some of these alternatives. Likewise, from the Choosing Wisely campaign, one of the top 5 things that the American Academy of Neurology says is don't use opioid or butalbital treatment for migraine except as a last resort. So again, I can refer patients to that, and this is something that can be pretty easily brought up and shown to the patients. The American Academy of Neurology and the American Headache Society both say opioids are not appropriate treatment for headaches. Additionally, it's been studied in a randomized control trial. So they randomized patients to compazine versus hydromorphone, and it was shown to be inferior. So it's not just that we're trying to avoid opioids in these patients for some larger side effect, addiction, et cetera, sort of purpose. Opioids like this are less effective for migraine headaches and can be associated with increased side effects. So I would stick with our antiemetics as our first line in our headache patients. So for our migraine pathway that we can kind of quickly walk you through in the ER, this is our pathway. It's stolen from a paper where they implemented this, I think, at Cleveland Clinic. But the step 1 is ketorolac, an anti-inflammatory, with an antiemetic. I would usually I like prochlorperazine as our first line, so it's kind of pre-checked and available. If you like metoclopramide, you can go with that. I guess I wouldn't start with ondansetron. It just doesn't have the dopaminergic actions that are likely to be as efficacious. Oops, now we gotta see this again. You can add diphenhydramine to try and help them maybe get a little nap and prevent some extrapyramidal symptoms, and some IV fluids as your first line is kind of step 1. Step 2, in this Cleveland Clinic protocol, they added Depakote to this, but we move on to dexamethasone and magnesium as kind of our second line. 2 grams of magnesium will be safe in patients who aren't in renal failure. They're not going to get hypermagnesiemic from that dose, so there's no need to really check a magnesium beforehand if you're moving on to this step. You can start with the dexamethasone and the mag. If that fails, we've got a variety of things we can try. So again, this is where we put in the Depakote option. Giving a gram of Depakote over 20 minutes can help with headache. Sumatriptan in this algorithm, as well as in ours, is actually first line. If your patient comes in saying, I have a migraine headache and I've taken triptans before and they've helped, I would try a triptan again in the emergency department. But otherwise, we usually move it to third line. And then there's ergotamine, which I think most people are probably not comfortable using in the emergency department without a neurology consult, and that's fine. But if you are, it's a reasonable medication to try. And you should add an antiemetic to that because it can make patients very nauseous. But usually adding the Depakote is a reasonable option. Again, you're assessing for contraindications, including uncontrolled hypertension. That's more with sumatriptan and ergotamine. Pregnancy for all of them, or history of stroke or coronary artery disease, again, particularly for the triptans and the ergotamine. But you want to assess for those contraindications, and then you can try some of these medications as a third line. And then upon discharge, they again, in this protocol from Cleveland Clinic, they make clear no opiate scripts are indicated. So you saw there's no furosemide in that pathway, there's no barbiturates, no opioids. So they found that when they instituted this pathway, they found less ED opioids and barbiturates were used, and it was persistent over time. So it has sustained effects on practice patterns, and there were less opioid and barbiturate prescriptions. So they did not need to move on to opioids for a lot of these patients. So that's what our protocol is based off of. You may have heard that some repeat low doses of propofol might be helpful for headaches. I've tried it. It helped with a patient. Probably wasn't worth the trouble. I mean, if you're doing it, you're doing a conscious sedation. Even though you're giving low doses, you're doing conscious sedation level monitoring on those patients, and it's probably not worth it. I might try, even though there might be a little less evidence for it, try some pain dose ketamine, those sorts of things. There's a couple of other things you can try. Intranasal lidocaine has been studied, a sphenopalatine ganglion block, which is basically you just stick a long nasal swab, which I don't know, maybe are reserved for COVID testing at this point, but you stick a long nasal swab into the patient's nose and you drip lidocaine down into their nose and let it kind of dwell in their posterior nasopharynx there. So that's a sphenopalatine ganglion block versus paracervical bupivacaine. All of these are thought to kind of modulate both sympathetic as well as pain pathways in the head and neck and help with pain. And so there's equivocal data for their use. Again, some studies of intranasal lidocaine find it very helpful. Some find no benefit. Likewise with sphenopalatine ganglion block, and there's a lot of anecdotal support for paracervical bupivacaine. You go in at C7 area and just do these paracervical injections of bupivacaine in their muscle bellies, and it's a safe and potentially helpful. So I'll move on to those, some sort of use of a local anesthetic for patients who are refractory to lots of things, who have a reason not to move on to a variety of other stuff. You can get started with those things. So what about our patients who are on medications for addiction treatment? What do we do for their acute pain treatment? Well, everything else applies, right? These are patients, again, who are exposed to opioids, who may not get good pain control from adding more opioids on top of it, and have risk from adding more opioids on top of it. So all of our alternatives to opiates apply here, right? And we definitely want to try them. That doesn't mean that all of the patients, won't benefit from adding any opioids on top of it, but we have to be thoughtful about adding those medications on. So what if we have a 27-year-old here, he has got acute pain, he's got an abscess, or maybe he's got acute on chronic back pain, but really can't get up and walk because of it. He's here with an acute fracture. He's got a real reason for pain, right? And we need to address their pain. They're here for cholecystitis. There's all sorts of reasons for acute pain that this patient might have that we really want to focus on. But what do we do if they're getting methadone or naltrexone or buprenorphine for their pain? So for our methadone patients, we just need to recognize that their maintenance methadone does not help with pain. It's an opioid, it's maintenance, it's not a pain medication. So even though they're on something like 500 morphine equivalents orally every day, this is not a pain medication, so they would need something on top of that. That is their maintenance medication. I would say you, and I usually try not to as well, should not be changing a patient's methadone dose to add more. That is not a safe way to treat patients' pain who are on methadone. Methadone titration is left to both opioid treatment programs, if it's for opioid use disorder, or pain specialists if it's done for pain. But do not mess around with a patient's methadone dose. What you have to recognize is these methadone patients have an extremely high tolerance. So that's what I'm talking about when I'm saying focus on the alternatives to opioid. They have, used up their opioid receptors' ability to help them with their pain, and we really should be focusing on other things. If narcotics are needed, again, we need to recognize they're gonna need a high dose. 50 milligrams of methadone is something like 500 milligrams of oral morphine a day. So if you give them 5 milligrams of IV morphine, you got to recognize that is equal to like 10 milligrams of oral morphine, and that is a drop in a bucket for that patient. And so they're going to require high doses if they really require opioid analgesia. So recognize that for those patients. patients who are on naltrexone, either IM is a month-long injection that might not show up on their medication record, or oral naltrexone at steady state has been shown to block up to 13.5 milligrams of hydromorphone over 2 hours. 13.5 milligrams IV dilaudid, given over 2 hours, was found to not really have any real drug effect to these patients who are therapeutic on naltrexone. So again, if you're trying to overcome the blockade of someone's naltrexone, we're talking super high doses, but it's been recommended that for patients who are on naltrexone, again, mild to moderate pain, we start with alternatives to opioids. If it's an elective issue, you want to wait 72 hours after the last oral dose, or 28 days at least after the last IM dose, if you're able to do it. But obviously, that doesn't apply to the emergency department. So if they're having emergency type pain, you can think about regional anesthesia, right? This is where our nerve blocks can really come in. You can move towards conscious sedation, and that's what I think our approach to these patients needs to be, right? If I'm saying give this patient 16 milligrams of hydromorphone, I think that they should have a degree of monitoring. It's not totally clear. There's interpatient variability. Maybe they actually didn't get their Vivitrol or naltrexone injection, and need, and so then they would actually have an effect from it. So you should treat them like a conscious sedation, or if they really need it, the patient is in a motor vehicle collision, you find out that they're on IM naltrexone, they're here with a bunch of facial fractures and a femur fracture, and they need to go to the CT scan, just intubate that patient, sedate them with as much opioids as it takes, as well as other meds, maybe add on a ketamine drip for pain, etc., and deal with them that way. But these patients have minimal efficacy for their opioids for their pain management. Buprenorphine, another medication we use for addiction treatment, can have some issues with pain management. Just know, right, that buprenorphine in blue will block full agonist opioids similarly to naltrexone. So it gives an opioid effect, but it'll block opioids as well in a similar degree to naltrexone. It'll bring them down from that red line down to the blue line, where you're not getting much benefit. No more benefit, I guess I should say, from the full agonist opioid than you would get from the buprenorphine in the first place. So buprenorphine blocks opioids like naltrexone, but we've got a couple of things we can do for their pain. I always say don't stop their home Suboxone. I've seen it time and again in the emergency department when a patient comes in with some degree of acute pain or acute on chronic pain, and they've stopped their home Suboxone, and next thing we do is we see them the next day and they're in withdrawal. Their pain is very severe because being in withdrawal exacerbates their pain. I would say do not stop the patient's home Suboxone before discussing it with their prescriber, or in our case, the addiction medicine team. If you want to start doing something for their pain, you can split their dose and potentially add a dose. So if they're on 16 milligrams daily, you can split it to 4 milligrams 4 times a day, and that has better pain control. Giving more frequent doses helps more with pain. You could either change it, you could also change it to 4 milligrams 5 times a day. You could, in the ER, you could basically just give them that one-time 4 milligram dose, or even 8 milligram dose to see if it helps. You can increase their dose if needed. Again, you can increase them up to 32 milligrams, so 8 milligrams 4 times a day, while we're working to figure it out. But again, for our acute pain, we're focusing on our Alto meds. Again, you can add this PRN, sublingual buprenorphine. Something like a third of the daily dose is usually a good starting point. So again, if they're on 24 milligrams, just give them an 8 milligram Suboxone, even if they took it that day. You can add on IV buprenorphine, has some benefit because it has such high affinity for the opioid receptor. It'll bind very strongly to it, so it'll actually provide a little analgesia where 100 mics of fentanyl might not. And again, if you're moving on to high dose opioids, you have to go high dose, as it blocks still somewhere in that 12 to 18 milligram range of hydromorphone, similar to naltrexone. So you're talking high dose, those sorts of things. So what about when we're queuing up our patients for discharge? What do we think that we should be doing for their pain control? And I think it's helpful to have some thoughts about how do our patients perceive pain. Help us understand, how do we make our patients satisfied with their pain control while they're in the emergency department? And so if we look at how people perceive pain, it can actually help us understand what our best approach would be. So we've got two patients here, patient A and patient B, who undergo a procedure. And these lines indicate what they would rate their pain score is during various points in the procedure. And then, of course, when it stops, the procedure is over, there's no pain. Who do you think, just looking at these graphs, who do you think experienced more pain? Patient A, whose pain was over after, say, 9 minutes, had these peaks, but it peaked no higher than patient B. Or patient B, who had this kind of longer term experience of pain. Who experienced more pain? Well, from our kind of medical perspective, we say, well, there's a higher area under the curve for patient B. There's more pain. They should say they have more pain. But in reality, what we find out is that people's retrospectively look back and say, how much pain did I have today, actually has more to do with kind of the average between the peak of the pain, what was the most pain I had today, what was my highest pain score, and their pain at the end of a procedure or event. So because patient A suffered a similar peak pain, but by the end of the procedure was still in a lot of pain, he would perceive himself as having more pain from that procedure than patient B, who was in pain for twice as long, but the pain kind of trailed off throughout the procedure, and he ended it on a fairly comfortable note. So the idea here being, again, they average their thought of the end pain and the peak pain. We can't do much about the peak pain, although we can treat their pain, as aggressively as we think is appropriate. But once we're at that level, we're not, we can't necessarily control it when they're already in pain. What we can control is, I feel like when I'm doing a abscess drainage or a fracture reduction or whatever it might be, and the nerve block or whatever is starting to wear off and the patient's starting to groan and grunt, and I say, okay, just white knuckle it there for a second, we're going to get you through it, and you just kind of push them through it. You might want to consider giving them an additional dose, blocking them again, etc., to help them control their pain towards the end of their procedure. If you want them to feel like they've experienced less pain, which is certainly our goal, if you want them to be more satisfied with their pain control, which is also our goal. So really remember to also consider their pain at the end, even though we want to move forward and move on with what we're doing. Considering the pain at the end of a procedure is an important thing to do. If you are considering opioid prescriptions on discharge, you should be having a discussion. Every opioid prescription should come with a discussion of how to take the medicine. You don't just throw a bottle of Norco at them. You have to talk with them about the risks of it. You have to talk about whether you think there's going to be benefit or whether they really should be focusing on their ibuprofen first. Talk with them about their expected course of their pain, right? You want to tell them, I expect your pain to be getting better over time. And so if it's getting worse and worse, maybe come back to the ER. Don't just keep taking your Norco, right? Because that's one of the risks if you prescribe high potency medications, that they're just going to sedate themselves with them while they're having worsening pathology. If they're having chronic pain, ACEP has an opioid guideline that says that that ER docs do not have to prescribe pain medications, opioids, for acute management of chronic disease, that those medications should be prescribed by a primary care or pain physician. So it's reasonable to tell your patient that I do not prescribe medications for the acute treatment of chronic pain in the ER. That's this is a chronic pain course, so treating out of the ER is inappropriate. They may have a pain contract, those sorts of things. So having that discussion with the patient. You want to talk about the home use of alternatives, right? You want to say, I want you taking ibuprofen 400 milligrams every 6 hours as the first thing. And only if the pain is getting up above that treatment, that's the only time I want you to use this. And then talk with them about what they should do. You should be having a discussion with the patients about what these medications are for and how to use them and what to use first, so they can know what to do. What we do know is that after patients are prescribed opioids in a variety of settings, that they have an increased risk of being on chronic opioids after, and it increases. What this graph shows is on the x-axis there, we see the day supply of the first opioid prescription, right? So if they get 1 day of, or if they say they get 5 days of opioids from prescribed to them, they actually have a 10% probability of still getting opioid prescriptions at 1 year, and like a 5% probability of still getting opioids at 3 years. Whereas if you write them for a 30-day prescription, and I know we don't do this from the ER, if you write them for a 30-day prescription, they're more likely to have a 1 out of 3 chance of being on chronic opioids after 1 year, and a 1 out of 5 chance of being on chronic opioids in a year at that point. So it just goes to say, 5 versus 10 actually has a doubling as well. So write for as short of a course of opioids as you think is appropriate. In other studies, we see that even after minor surgical procedures, patients have an increased use of chronic opioids. So what they found in this study of patients undergoing surgery, found that who were prescribed opioids after these minor procedures had a 6% chance of persistent opioid use after minor surgery. Or you could think of it as a minor procedure in the ER, something like that, that they had a 6% chance. And the procedures we're talking about were a hemorrhoidectomy, carpal tunnel surgery, varicose veins, procedures that are not significantly painful, could be managed with opioids, without opioids, but those who were prescribed had a 6% chance of persistent opioid use at a year. So patients do stay on opioids after they're prescribed. It happens in the ER as well. The overall prevalence is low. The impact of the ER on things like the opioid crisis is relatively low. That, again, most of it comes from these big 30-day prescriptions and things. But it's been shown in the New England Journal of Medicine, they did a study and they looked back and saw that amongst patients who came to the ER, those who encountered high opioid prescribers, so those who prescribed opioids to a high percentage of their patients, had a higher incidence of long-term opioid use, about 1.5%, as compared to those who encountered low opioid prescribers. So this single kind of contact with somebody who's more likely to prescribe them opioids increased their risk of persistent opioid use. Again, a relatively small amount by 0.3%, but we see a lot of patients. And so again, being thoughtful about who you prescribe opioids to and the duration is important. So like I said, the opioids can be avoided for many kinds of pain. They might be necessary, but if they are necessary, don't forget that adding multimodal therapy can help with the patient's pain, and we have all sorts of options. We have our Alto protocol. We got different things we can try for patients. Any questions? I saw there was some text going through there, if I can try and pull them up, but any questions I can answer on that? Chat.
I think I saw 2 questions on there, Henry. One was about why the preference for Compazine versus Reglan, and the other one is IV versus PO Benadryl.
There was a study that showed it says my internet connection is unstable again. There was a study that showed higher benefit from prochlorperazine compared to metoclopramide. So that's my reason for checking it, is that, and sometimes you need higher doses of metoclopramide and end up getting more side effects from it. It can be effective as well. So I think it's probably just a little more effective, but it doesn't matter too much. It's my preference. I can send out that study, and the IV Benadryl, yeah, there's not a great reason. Is that it's faster in onset. Again, it'll kind of put them to sleep. I definitely try and avoid IV Benadryl for patients who are getting opioids. There's a high preference and a highly reinforcing effect from it. But yeah, you could definitely give your migraineurs some PO Benadryl as well. Dan had asked about, surgeon perceptions that Toradol can lead to more procedural bleeding. I haven't looked into that. I should ask a surgeon if there's data on it. I think it may be anecdotal, as well as, there's kind of basic science evidence that these NSAIDs block the inflammatory cascade, and that blocks platelet activation and all this stuff. So, I think that, depending on the magnitude of the surgery they might be going under, kind of alters how much I worry about that sort of thing. But I'll try and dig into that some more. And yes, the studies from Chase, the studies were all first-time prescriptions looking at incidence of persistent opioid use. So it's new persistent opioid use for those patients. For whether they would have persistent opioid use. And it looks like, we got the academic life in EM, why prochlorperazine in migraine might be better. In general, the studies on Prescoganian opioid prescriptions show that there's no improvement in patient satisfaction, whether they get opioid prescriptions or not, kind of across the board. I guess what I would say is that I remember there's one that I'm going to try and dig up that did show kind of some increased patient satisfaction. I think it depends on what patients you're talking about, right? And so when they say, oh, well, patients care whether they get opioid prescriptions or not, I mean, we all know that's not true. We've all had the patient who storms out angrily when they don't get their opioids, even if you're having a reasonable conversation with them. So I don't know, to me, it points at kind of the inappropriateness of using this patient satisfaction as a metric for our medical treatment of the patients. But for the most part, there is not a Presgani benefit from prescribing opioids. And if there is, the magnitude is small. So I would not use that. You know, we are physicians, we first do no harm. So I wouldn't use that as a reason to write opioid prescriptions. I do think that IV, IV Tylenol is probably more available internationally. Again, the main reason not to use it in the U.S. is this is exorbitant cost, which is kind of a unique thing to the U.S. healthcare system. So.
Cool. Nice job. Thanks, Henry.
Yep, no problem.